talk about spinal cord injury. Spinal cord injury. In your nursing assessment, you want to obtain a health history from the patient, including the cause of the spinal cord injury. Obtain the following important health information related to pertinent functional health patterns: health perception and health management, the use of alcohol or recreational drugs and risk-taking behaviors, activity exercise. Look at loss of strength, movement, and sensation below the level of the injury, dyspnea, inability to breathe adequately, or air hunger. Cognitive perceptual, the presence of tenderness, pain at or above the level of the injury, numbness, tingling, burning, twitching of the extremities. And coping stress tolerance, look for fear, anger, denial, and depression. Your objective assessment should be focused on the following areas. In general, look for poikilothermism, which again is the inability to regulate body heat. Look for warm, dry skin below the level of the injury, indicating neurogenic shock. Look for look for apnea and the inability to cough if the injury is at C1 to C3. Look for poor cough and diaphragmatic breathing and hypoventilation if the injury is at C4. Look for decreased respiratory reserve if the injury is C5 to T6. Look for bradycardia, hypotension, postural hypotension in the absence of vasomotor tone if the injury is above T5. And you'll find decreased or absent bowel sounds, a paralytic ileus in injuries above T5, and abdominal distension, constipation, fecal incontinence, and fecal impaction. You want to look for urinary retention for injuries between T1 and L2, a flaccid bladder in the acute stages, and spasticity with reflex bladder emptying in the latter stages. As for reproductive, look for priapism or loss of sexual function. Neurologic, look for flaccid paralysis and anesthesia below the level of injury, resulting in tetraplegia for injuries above C8 or paraplegia for injuries below C8. Hyperactive deep tendon reflexes, bilaterally positive Babinski tests after resolution of the spinal shock. And for incomplete trauma, you look for mixed loss of voluntary motor activity and sensation. And in musculoskeletal area, look for muscle atony in the flaccid state and contractures in the spastic state. Nursing diagnoses for the patient with a spinal cord injury depend on the severity of the injury and the level of dysfunction. The nursing diagnoses for a patient with a spinal cord injury may include, but are not limited to, ineffective breathing pattern related to respiratory muscle fatigue, neuromuscular paralysis, and/or retained secretions, and impaired skin integrity related to immobility and/or poor tissue perfusion, an impaired urinary elimination related to spinal injury and/or a limited fluid intake, constipation related to neurogenic bowel, inadequate fluid intake and/or immobility, and risk for autonomic dysreflexia related to reflex stimulation of sympathetic nervous system. The overall goals that the patient with a spinal cord injury will maintain the optimal level of neurologic function, have minimal or no complications of immobility, learn new skills, gain new knowledge, and acquire new behaviors to be able to care for themselves or successfully direct others to do so, and return to home and the community at an optimal level of functioning. Nursing interventions for the prevention of a spinal cord injury include identification of high-risk populations, counseling, and teaching. Supportive legislation related to seatbelt use in cars, helmets for motorcyclists and bicyclists, child safety seats, and tougher penalties for drunk driving offenses is a professional responsibility. It's important to emphasize the importance of other health promotion and health screening in addition to spinal cord injury care. After injury, health promoting behaviors can have a significant impact on health and well-being of the individual with a spinal cord injury. Nursing interventions include teaching, counseling, and referral to programs such as smoking cessation classes, recreation and exercise programs, and alcohol treatment programs, and maintaining routine physical examinations for non-neurologic problems. Outpatient health care requires that screening and prevention programs be accessible for people with spinal cord injury. Nurses in these settings should facilitate wheelchair-accessible examination rooms, adjustable height examination tables, and scheduling that allows extra time if needed. Proper immobilization of the neck involves the maintenance of the neutral position. Use a blanket or towel roll, a hard cervical collar, and a backboard to stabilize the neck to prevent lateral rotation of the cervical spine. The body should always be correctly aligned. Turning should be performed so that the patient is moved as a unit, called log rolling, to prevent movement of the spine. JN is sent to the OR for surgical stabilization of her spine. Her family tells you that a friend had a cervical fracture who was treated with traction. They asked you to explain the difference in treatment. What is cervical traction? For cervical injuries, skeletal traction is used less frequently with the development of better surgical stabilization. When skeletal traction is used, realignment or reduction of the injury is targeted. Crutchfeld, Vinke, or Gardner-Wells tongs or other types of devices are used to provide this type of traction. Traction is provided by a rope that's extended from the center of the tongs over a pulley and has weights attached at the end. Traction must be maintained at all times. Depending on the type of injury and the goal of treatment, the tongs and traction may be removed 1 to 4 weeks after the injury. One disadvantage of skull tongs is that the skull pins can be displaced. If this occurs, hold the head in the neutral position and summon help. Stabilize the head while the physician reinserts the tongs. Infection at the site of tong insertion is another potential problem. Preventive care includes cleansing the site twice a day with normal saline and applying an antibiotic ointment, which acts as a mechanical barrier to the entrance of bacteria. The procedure for preventive care of insertion sites may vary depending on the individual hospital standards of care. This is an example of Gardner-Wells tongs. Special beds are used in the management of the patient with spinal cord injury. Kinetic therapy uses a continual side-to-side slow rotation laterally with the patient in constant motion. The bed allows a frequency of turns greater than 200 times a day. The bed is used to decrease the likelihood of pressure sores and cardiopulmonary complications. However, in some patients, the turning can induce motion sickness and fear of falling out of bed when turned to the extreme. Motion sickness is unlikely when automatic rather than manual turning is used. This is an example of one of those beds. A SOMI brace is used after cervical fusion and other stabilization surgery, and it's a hard cervical collar or sternal occipital mandibular immobilizer brace, SOMI. In a stable injury for which surgery is not done, a halo fixation apparatus may be applied. The halo is the most frequently used method of stabilizing cervical injuries. The halo apparatus can be used to apply cervical traction by means of a jacket-like arrangement. Hanging weights such as those used with tongs can be incorporated with the halo. In addition, the apparatus can be attached to a body vest, stabilizing the injured area and allowing ambulation if the patient is neurologically intact. Another alternative is to use the halo after the patient has had traction removed. It allows the patient to be more mobile and to begin active rehab. Patients with thoracic or lumbar spine injuries are immobilized with a custom thoracolumbar or orthosis or body jacket, which inhibits spinal flexion, extension, and rotation, or with a Jewett brace, which restricts forward flexion. Immobilization of the neck of the patient with the spinal cord injury prevents further injury, but the effects of immobility are profound. Meticulous skin care is critical because decreased sensation and circulation make the patient particularly susceptible to skin breakdown. Remove patients from backboards as soon as possible and replace them with other forms of immobilization to prevent coccygeal and occipital area skin breakdown. Properly fit cervical collars. Inspect the areas under the halo vest or jacket or under braces or orthoses to assess the skin condition. What would be your priority assessment of JN's condition upon her return from surgery? During the first 48 hours after injury, spinal cord edema may increase. The level of dysfunction and respiratory distress may occur. The possibility of respiratory arrest requires careful monitoring and prompt action should it occur. If the injury is at or above C3, or if the patient is exhausted from labored breathing, or ABGs deteriorate, indicating inadequate oxygenation or ventilation, endotracheal intubation or tracheostomy and mechanical ventilation should be initiated. Pneumonia and atelectasis are potential problems because of reduced vital capacity and the loss of intercostal and abdominal muscle function, resulting in diaphragmatic breathing, pooled secretions, and an ineffective cough. Regularly assess breath sounds, arterial blood gases, tidal volume, vital capacity, skin color, breathing patterns, especially the use of accessory muscles, subjective comments about the ability to breathe, and the amount and color of sputum. The PO2 greater than 60 and a PCO2 of less than 45 are acceptable values in a patient with uncomplicated tetraplegia. A patient who is unable to count to 10 aloud without taking a breath needs immediate attention. In addition to monitoring, you can intervene to maintain ventilation. Aggressive chest PT, adequate oxygenation, and proper pain management are essential to maximize respiratory function and gas exchange. Administer oxygen until ABGs stabilize. Chest PT and assisted cough facilitate the raising of secretions. Assisted or augmented coughing simulates the action of the ineffective abdominal muscles during the expiratory phase of a cough. Place the heels of both hands just below the xiphoid process and exert firm upward pressure to the area timed with the patient's efforts to cough. And perform tracheal suctioning if crackles or rhonchi are present. Incentive spirometry is an added technique that can be used to improve the patient's respiratory status. Because of the unopposed vagal response, the heart rate is slowed, often to less than 60 beats a minute. Any increase in vagal stimulation, such as turning or suctioning, can lead to cardiac arrest. Loss of sympathetic nervous system tone in peripheral vessels results in chronic low blood pressure with potential postural hypotension. Lack of muscle tone to aid venous return can result in sluggish blood flow and predispose the patient to DVTs. Frequent assessment of vital signs is important. If blood loss has occurred from other injuries, H&H levels should be monitored, and blood should be administered according to protocol. Also monitor the patient for indications of hypovolemic shock secondary to hemorrhage. Assess the thighs and calves of the legs every shift for signs of DVT. So, for example, a deep reddish color or edema. If bradycardia is symptomatic, an anticholinergic drug like atropine is administered. A temporary or permanent pacemaker may be inserted in some patients. Hypotension is managed with a vasopressor agent, such as dopamine or norepinephrine, and fluid replacement. Sequential compression devices or compression gradient stockings can be used to prevent thromboemboli and to promote venous return. Remove the stockings every 8 hours for skin care. Venous Doppler or venous duplex studies may be performed before applying compression devices. Also, regularly perform range of motion exercises and stretching. Prophylactic heparin or low molecular weight heparin, such as enoxaparin, may be used to prevent DVT unless it's contraindicated. Contraindications include internal bleeding and recent surgery. During the first 48 to 72 hours after the injury, the GI tract may stop functioning, called paralytic ileus, and the nasogastric tube must be inserted. Because the patient can't have oral intake, monitor carefully fluid and electrolyte status. Specific solutions and additives are ordered based on individual requirements. Once bowel sounds are present or flatus is passed, oral foods and fluids can gradually be introduced. Because of severe catabolism, a high-protein, high-calorie diet is necessary for the patient in tissue repair, for energy and tissue repair. In patients with high cervical cord injuries, evaluate swallowing before starting oral feedings. If the patient is not able to resume eating, enteral or parenteral nutrition may be used to provide nutritional support. Some patients experience anorexia, which can be due to depression, boredom with institutional food, or discomfort at being fed, often by a harried nurse or hurried nurse. Some patients have a normally small appetite. Occasionally, refusal to eat is used as a means of maintaining control over the environment because of diminished or absent body control. If the patient is not eating adequately, thoroughly assess the cause. On the basis of this assessment, a contract may be made with the patient using mutual goal setting regarding the diet. This gives the patient increased control of the situation and often results in improved nutritional intake. General measures such as providing a pleasant eating environment, allowing adequate time to eat, including any self-feeding the patient can achieve, encouraging the family to bring in special foods, and planning social rewards for eating may be useful. Keep a calorie count and record the patient's daily weight as a means of evaluating progress. If feasible, the patient should participate in recording calorie intake. Dietary supplements may be necessary to meet nutritional needs. Increased dietary fiber should be included to promote bowel function. Avoid using the patient's nutritional intake to become a basis for a power struggle. JN is concerned about how she'll be able to control her bladder and bowel with her current status. How would you respond to her? Immediately after the injury, urine is retained because of the loss of autonomic and reflex control of bladder and sphincter. Because there's no sensation of fullness, overdistension of the bladder can result in reflux into the kidneys with eventual renal failure. Bladder overdistension may even result in rupture of the bladder. Consequently, an indwelling catheter is usually inserted as soon as possible after the injury. Ensure patency of the catheter by frequent inspection and irrigation if it's necessary. In some institutions, a physician's order is required for this procedure. Strict aseptic technique for catheter care is essential to avoid introducing infection. During the period of indwelling catheterization, a large fluid intake is required. Check the catheter to prevent kinking and ensure free flow of urine. UTIs are a common problem. The best method for preventing UTI is regular and complete bladder drainage. After the patient is stabilized, assess the best means of managing long-term urinary function. Usually the patient is started on an intermittent catheterization program. Intermittent catheterization should be done every 3 or 4 hours to prevent bacterial overgrowth resulting from urinary stasis. If the appearance or odor of the urine is suspicious, or if the patient develops symptoms of a UTI such as chills, fever, or malaise, a specimen should be sent for culture. Constipation is generally a problem during spinal shock because no voluntary or involuntary reflex evacuation of the bowel occurs. A bowel program should be started during acute care. This consists of choosing a rectal stimulant or suppository or small volume enema to be inserted daily at a regular time of day, followed by gentle digital stimulation or manual evacuation until evacuation is complete. Initially, the program may be done in bed in the side-lying position, but as soon as the patient has resumed sitting, it should be done in the upright position on padded bedside commode chair. Because there is no vasoconstriction, piloerection, or heat loss through perspiration below the level of the injury, temperature control is largely external to the patient. Monitor the environment closely to maintain an appropriate temperature. Also, regularly monitor body temperature. Do not overload patients with covers or unduly expose them, such as during bathing. If an infection with high fever develops, more extensive means of temperature control, such as a cooling blanket, may be necessary. Stress ulcers are a problem for a patient with a spinal cord injury because of the physiologic response to severe trauma and psychological stress. Peak incidence of stress ulcers is 6 to 14 days after the injury. Test stool and gastric contents daily for blood and monitor the crit for a slow drop. H2 receptor blockers like ranitidine, famotidine, or a proton pump inhibitor may be given prophylactically to decrease the secretion of hydrochloric acid and prevent the occurrence of ulcers during the initial phase. You need to compensate for the patient's absent sensations to prevent sensory deprivation. Do this by stimulating the patient above the level of the injury. Conversation, music, and interesting food can be part of the nursing care plan. Provide prism glasses so that a patient can read and watch television. Make every effort to prevent the patient from withdrawing from the environment. Patients with spinal cord injury often report altered sensorium and vivid dreams during the acute phase of their treatment. Whether this is due to the drugs used to manage pain and anxiety is not known. Patients may also experience disrupted sleep patterns as a result of the hospital environment or post-traumatic stress disorder. Once spinal cord shock is resolved, the return of reflexes may complicate rehab. Lacking control from the higher brain centers, reflexes are often hyperactive and produce exaggerated responses. Penile erections can occur from a variety of stimuli causing embarrassment and discomfort. Spasms ranging from mild twitches to convulsive movements below the level of the injury may also occur. This reflex activity may be interpreted by the patient or caregiver as the return of function. Tactfully explain the reason for the activity. Inform the patient of the positive use of these reflexes as sexual, bowel, and bladder retraining. Spasms may be controlled with the use of antispasmodic drugs such as baclofen, dantrolene, and tizanidine. Botulism toxin injections may also be given to treat severe spasticity. Some of CN's reflexes have returned. You walk in her room one morning to find her pale and diaphoretic. She's complaining of a pounding headache. You assess her vital signs and find her blood pressure is 206/100 and her heart rate is 56 beats a minute. What do you suspect is going on with JN? It's called autonomic dysreflexia. The return of reflexes after the resolution of spinal shock means that patients with the level injury at T6 or higher may develop autonomic dysreflexia. Autonomic dysreflexia is also known as autonomic hyperreflexia. It's a massive, uncompensated cardiovascular reaction mediated by the sympathetic nervous system. It involves stimulation of sensory receptors below the level of the spinal cord injury. The intact sympathetic nervous system below the level of the injury responds to the stimulation with a reflex arteriolar vasoconstriction that increases blood pressure, but the parasympathetic nervous system is unable to directly counteract these responses via the injured spinal cord. Baroreceptors in the carotid sinus and the aorta sense the hypertension and stimulate the parasympathetic system. This results in a decrease in heart rate, but the visceral and peripheral vessels do not dilate because efferent impulses cannot pass through the injured spinal cord. What would be the most likely cause of autonomic dysreflexia in JN? Well, the most common precipitating factor of autonomic dysreflexia is a distended bladder or rectum. However, any sensory stimulation may cause autonomic dysreflexia. Contraction of the bladder or rectum, stimulation of the skin, or stimulation of the pain receptors may also cause autonomic dysreflexia. Manifestations include hypertension up to 300 millimeters of mercury systolic, throbbing headache, marked diaphoresis above the level of the injury, and bradycardia at 30 to 40 beats a minute. It's less important to measure the BP when the patient with a spinal cord injury complains of a headache. So for what other clinical manifestations of autonomic dysreflexia will you assess JN? Additional clinical manifestations include piloerection, which is erection of body hair or goosebumps as a result of pilomotor spasm, flushing of the skin above the level of the injury, blurred vision or spots in the visual field, nasal congestion, anxiety, and nausea. So what are the appropriate interventions for JN at this point? The condition is a life-threatening situation that requires immediate resolution. If resolution does not occur, this condition can lead to status epilepticus, stroke, myocardial infarction, and even death. Nursing interventions in this serious emergency are elevation of the head of the bed 45 degrees or sitting the patient upright, notification of the physician, and assessment to determine the cause. The most common cause is bladder irritation. Immediate catheterization to relieve bladder distension may be necessary. Lidocaine jelly should be instilled into the urethra before catheterization. If a catheter is already in place, it should be checked for kinks or folds. If plugged, small volume irrigations should be performed slowly and gently to open a plugged catheter, or a new catheter may be inserted. Stool impaction can also cause autonomic dysreflexia. A digital rectal exam should be performed only after application of an anesthetic ointment to decrease rectal stimulation and to prevent an increase in symptoms. Remove all skin stimuli such as restrictive clothing or tight shoes. Monitor BP frequently during the episode. If symptoms persist after the source has been relieved, a beta blocker or an arterial or vasodilator like nifedipine is administered. Careful monitoring must continue until the vital signs stabilize. Teach the patient and caregiver to recognize the causes and symptoms of autonomic dysreflexia. They must understand the life-threatening nature of this dysfunction and know how to relieve the cause. Rehab of the patient with a spinal cord injury is complex. With physical and psychological care and intensive and specialized rehab, the patient with a spinal cord injury can learn to function at the highest level of wellness. It is recommended that all patients with a new spinal cord injury receive comprehensive inpatient rehab in a rehab unit or center that specializes in spinal cord rehab. Many of the problems identified in the acute period become chronic and continue through life. Rehab focuses on retraining of physiologic processes and extensive patient, caregiver, and family teaching about how to manage the physiologic and life-changing results of the injury. Rehab is an interdisciplinary endeavor carried out through a team approach. Team members include rehab nurses, physicians, physical therapists, occupational therapists, speech therapists, vocational counselors, psychologists, therapeutic recreation specialists, prosthetists, orthotists, and dietitians. Rehab care is organized around the individual patient goals and needs. During rehab, the patients are expected to be involved in therapies and learn self-care for several hours each day. Such intensive work at a time when the patient is dealing with a sudden change in health and functional status can be very stressful. Progress may be slow. The rehab nurse has a pivotal role in providing encouragement and specialized nursing care and patient and caregiver teaching and helping to coordinate the efforts of the rehab team. This is a depiction of a patient participating in occupational therapy. The patient with a high cervical spinal cord injury may have greatly increased mobility with phrenic nerve stimulators or electronic diaphragmatic pacemakers. These devices are not appropriate for all ventilator-dependent patients, but may be helpful for those with an intact phrenic nerve. Ventilators are also reasonably portable, and ventilator-dependent tetraplegic patients can be mobile and somewhat independent. Patients and caregivers should be taught all aspects of home ventilator care, and referrals should be made to the appropriate community agencies. Teach patients with cervical level injuries who are not ventilator dependent assisted coughing, regular use of incentive spirometry, or deep breathing exercises. A neurogenic bladder is any type of bladder dysfunction related to abnormal or absent bladder innervation. After spinal cord shock resolves, depending on the completeness of the spinal cord injury, patients usually have some degree of neurogenic bladder. Normal voiding requires nervous system coordination of urethral and pelvic floor relaxation with simultaneous contraction of the detrusor muscle. Depending on the injury, a neurogenic bladder may have no reflex detrusor contractions, so they are areflexic and flaccid. They may have hyperactive reflex detrusor contractions, so they're hyperreflexic and spastic, or they may have lack of coordination between detrusor contraction and urethral relaxation, called dyssynergia. Common problems with neurogenic bladder include frequency, urinary urgency and incontinence, inability to void, and high bladder pressures resulting in reflux of urine into the kidneys. Many factors are considered when selecting a bladder management strategy. These include the preference of the patient, upper extremity function, availability of a caregiver, and lifestyle choices. The type of bladder dysfunction also determines management options. Various drugs can be used to treat neurogenic bladders. Anticholinergic drugs such as ditropan, detrol may be used to suppress bladder contractions. Beta blockers such as Hitrin and Cardura can be used to relax the urethral sphincter, and antispasmodic drugs like baclofen can be used to decrease spasticity of pelvic floor muscles. Numerous drainage methods are possible, including bladder reflex retraining if partial voiding control remains, indwelling catheter, intermittent catheterization, and external catheter, also called a condom catheter. Evaluate the long-term use of an indwelling catheter because of the associated high incidence of UTI, fistula formation, and diverticula. However, there may be patients for whom this is the best option. Patients with indwelling catheters need to have an adequate fluid intake of at least 3 to 4 liters a day. Regularly check the patency of the indwelling catheter. The frequency of routine catheter changes ranges widely depending on the type of catheter used and agency policy. Intermittent catheterization is the most commonly recommended method of bladder management. Nursing assessment is important in selecting the time interval between catheterizations. Initially, catheterization is done every 4 hours. Bladder volume can be assessed before catheterization using the portable bladder ultrasound machine. If less than 200 milliliters of urine is measured, the time interval can be extended. If greater than 500 milliliters of urine is measured, the time interval is shortened. The number of intermittent catheterizations per day is usually 5 or 6. Urinary diversion surgery may be necessary if the patient has repeated UTIs with renal involvement or repeated stones, or if therapeutic interventions have been unsuccessful. Surgical treatment of neurogenic bladder requires bladder neck revision called sphincterotomy, bladder augmentation cystoplasty, penile prosthesis, artificial sphincter, perineal ureterostomy, cystotomy, vesicotomy, and anterior urethral transplantation. Urinary diversionary procedures are discussed in Chapter 46. No matter which bladder management strategy is selected, teach the patient, caregiver, and family how to accomplish successful self-management. Inform them about management techniques, how to obtain necessary supplies, care of supplies and equipment, and when to seek health care. Arrange for resources and referrals for supplies and ongoing care. Careful management of bowel evacuation is necessary in the patient with a spinal cord injury because voluntary control of this function may be lost. This condition is called neurogenic bowel. The usual measures for preventing constipation include a high-fiber diet and adequate fluid intake. However, these measures by themselves may not be adequate to stimulate evacuation. In addition, suppositories such as bisacodyl or Dulcolax or glycerin or small volume enemas and digital stimulation performed 20 to 30 minutes after suppository insertion by the nurse or patient may be necessary. In the patient with an upper motor neuron injury, digital stimulation is necessary to relax the external sphincter to promote defecation. A stool softener such as docusate sodium or Colase can be used to regulate stool consistency. Oral stimulant laxatives should only be used if absolutely necessary for a day or two and not on a regular basis. Valsalva maneuver and manual stimulation are used in patients with lower motor neuron injuries. The Valsalva maneuver requires intact abdominal muscles, so it's used in those patients with injuries below T12. Timing of defecation may also be an important factor. If bowel evacuation is planned for 30 to 60 minutes after the first meal of the day, this may enhance success by taking advantage of the gastrocolic reflex induced by eating. This reflex may also be stimulated by drinking a warm beverage immediately following the meal. In general, a bowel movement every other day is considered adequate. However, pre-injury patterns should be considered. Fecal incontinence can result from too much stool softener or a fecal impaction. Carefully record bowel movements. Remember that patient, caregiver, and family teaching is required to promote successful independent bowel management. Prevention of pressure ulcers and other types of injury to insensitive skin is essential for every patient with a spinal cord injury. Nurses in rehabilitation are responsible for teaching these skills and providing information about daily skin care. A comprehensive visual and tactile examination of the skin should be done at least once daily, with special attention given to areas over bony prominences. The area most vulnerable to breakdown include ischia, trochanter's, heels, and sacrum. Initially, careful position and reposition every 2 hours is important, with gradual increases in the time between turns if there's no redness over bony prominences at the time of turning. Pressure-relieving cushions may be used in wheelchairs, and special mattresses may also be needed. Movement during turns and transfers should be done carefully to avoid stretching and folding of soft tissues, a shearing force, as well as friction and abrasion. Assess nutritional status regularly. Both body weight loss and weight gain can contribute to skin breakdown. Adequate intake of protein is essential for skin health. Measurement of prealbumin, total protein, and albumin can help identify inadequate protein intake. Stress the importance of nutrition to skin health to the patient and caregiver. Protection of the skin also requires avoidance of thermal injury. Burns can be caused by hot foods or liquids, bath or shower water that's too warm, radiators, heating pads, and uninsulated plumbing. Thermal injury can also result from extreme cold. Injuries may not be noticed until severe damage is done. Anticipatory guidance about potential risks is essential. JN is worried how this spinal cord injury will affect her sexual abilities. What will you teach her? Sexuality is an important issue regardless of the patient's age or gender. To provide accurate and sensitive counseling and teaching about sexuality, you need to be aware of your own sexuality, as well as understand human sexual responses. When discussing sexual potential, use scientific terminology rather than slang whenever possible. Knowledge of the level and completeness of injury is needed to understand the male patient's potential for orgasm, erection, and fertility, and the patient's capacity for sexual satisfaction. Men normally have two types of erections, psychogenic and reflex. The process of psychogenic erection begins in the brain with sexual thoughts. Signals from the brain are then sent through the nerves of the spinal cord down to the T10, L2 levels. The signals are then relayed to the penis and trigger an erection. A reflex erection occurs with direct physical contact to the penis or other erotic areas. A reflex erection is involuntary and can occur without sexually stimulating thoughts. These reflex erections are often short-lived and uncontrolled and cannot be maintained or summoned at the time of coitus. The nerves that control a man's ability to have a reflex erection are located in the sacral nerves, S2 to 4, of the spinal cord. For men with a spinal cord injury, the ability to have a psychogenic erection depends on the level and extent of injury. Generally, men with low-level incomplete injuries are more likely to have psychogenic erections than men with high-level incomplete injuries. Men with complete injuries are less likely to experience psychogenic erections. However, most men with spinal cord injury are able to have a reflex erection with physical stimulation regardless of the extent of the injury if the S2 to S4 nerve pathways are not damaged. Because each spinal cord injury is different, the impact of injury on sexual function can also differ. Treatment for erectile dysfunction includes drugs, vacuum devices, and surgical procedures. Viagra has become the treatment of choice in men with spinal cord injury. Penile injection of vasoactive substances is another medical treatment. Risks include priapism and scarring, so these substances are often considered only after failure of sildenafil or Viagra. Vacuum suction devices use negative pressure to encourage blood flow into the penis. Erection is maintained by a constriction band placed at the base of the penis. The main surgical option is implantation of a penile prosthesis. Male fertility is affected by spinal cord injury, causing poor sperm quality and ejaculatory dysfunction. Recent advances in methods of retrieving sperm, penile vibratory stimulation, and electroejaculation, combined with ovulation induction and intrauterine insemination of the female partner, have changed the prognosis for men with spinal cord injury to father children from unlikely to a reasonable possibility of successful outcomes. The effect of spinal cord injury on female sexual response is less clear. Lubrication is similar to erection in males with reflex and psychogenic components. Women with upper motor neuron injuries may retain the capacity for reflex lubrication, whereas psychogenic lubrication depends on completeness of injury. Orgasm is reported by about 50% of women with spinal cord injury. The woman of childbearing age with a spinal cord injury usually remains fertile. The injury does not affect the ability to become pregnant or to deliver normally through the birth canal. Menses may cease for as long as 6 months after the injury. If sexual activity is resumed, protection against an unplanned pregnancy is necessary. The normal pregnancy may be complicated by UTIs, anemia, and autonomic dysreflexia. Because uterine contractions are not felt, a precipitous delivery is always a danger. Open discussion with the patient regarding sexual rehabilitation is essential. This important aspect of rehabilitation should be handled by someone specially trained in sexual counseling. A nurse or other rehabilitation professional with less such experience works with the patient and partner to provide support with an emphasis on open communication. As a nurse, you should respect every couple's personal standards of religious and cultural beliefs. Alternative methods of obtaining sexual satisfaction, such as oral genital sex, cunnilingus, and fellatio, may be suggested. Explicit films may also be used, such as a film demonstrating the sexual activities of a patient with paraplegia and a non-disabled partner. Graphics should be used cautiously because they may be too limiting or focus too much on the mechanics of sex rather than on the relationship. Care should be taken not to dislodge an indwelling catheter during sexual activity. If an external catheter is used, it should be removed before sexual activity, and the patient should refrain from fluids. The bowel program should include evacuation the morning of sexual activity. The partner should be informed that incontinence is always possible. The woman may need a water-soluble lubricant to supplement diminished vaginal secretions and facilitate vaginal penetration. The injury does not affect the ability to become pregnant or to deliver normally through the birth canal. As mentioned earlier, menses can cease for as long as 6 months after injury. If sexual activity is resumed, protect against an unplanned pregnancy. A normal pregnancy may be complicated by UTIs, anemia, and autonomic dysreflexia. And because uterine contractions are not felt, a precipitous delivery is always a possibility. Patients with spinal cord injuries may feel an overwhelming sense of loss. They may temporarily lose control over everyday life activities and must depend on others for ADLs and for life-sustaining measures. Patients may believe that they are useless and burdens to their family. At a stage when independence is often of great importance, they may be totally dependent on others. With recent advances in rehab, it's usual for the patient to be independent physically and discharged from the rehab center before completion of the grief process. The goal of recovery is related more to adjustment than to acceptance. Adjustment implies the ability to go on with living with certain limitations. Although the patient who is cooperative and accepting is easier to treat, expect a wide fluctuation of emotions from a patient with a spinal cord injury. Your role in grief work is to allow mourning as a component of the rehab process. Maintaining hope is an important strategy during the grieving process and should not be interpreted as denial. During the shock and denial stage, reassure the patient. During the anger stage, assist the patient in achievement of control over the environment, particularly by allowing the patient's input into the plan of care. Do not respond to anger or manipulation or become involved in a power struggle with the patient. As self-care abilities increase, the patient's independence increases. The patient's caregiver and family also require counseling to avoid promoting dependency in the patient through guilt or misplaced sympathy. The family is also experiencing an intense grieving process. A support group of family members and friends of patients with spinal cord injury can help increase family members' knowledge of and participation in the grieving process, the physical difficulties, the rehab plan, and the meaning of the disability in society. During the stage of depression, be patient. Sympathy is not helpful. Treat the patient as an adult and encourage participation in care planning. A primary nurse relationship is helpful. Staff planning and sessions in which staff members can express their feelings are helpful in providing consistency of care. To achieve the stage of adjustment, the patient needs continual support throughout the rehab process in the forms of acceptance, affection, and caring. Be attentive when the patient needs to talk and sensitive to needs at various stages of the grief process. Although the stage of depression during the grief process usually lasts days to weeks, there are some individuals who may become clinically depressed and require treatment for depression. Evaluation by a psychiatric nurse or psychiatrist is recommended. Treatment may include drugs and therapy. The expected outcomes of patient care will be the patient will maintain adequate ventilation and have no signs of respiratory distress, and maintain intact skin over bony prominences. They'll establish a bowel management program based on neurologic function and personal preference, and they'll maintain a bowel movement every other day. They'll establish bladder management program based on neurologic function, caregiver status, and lifestyle choices. They'll develop no complications of immobility and experience no episodes of dysreflexia. Because of increased work and recreational activities of older adults, more older adults are experiencing spinal cord injuries. Falls are the leading cause of spinal cord injury for people 65 and older. Besides having greater mortality rates, older adults with traumatic injuries experience more complications than younger ones, and they are hospitalized longer. The demographics of patients living with spinal cord injury are changing. The fact that persons with spinal cord injury now have longer lifespans has contributed to the increasing number of older adults living with a spinal cord injury. Aging is also associated with an increased occurrence of other chronic illnesses in a person with a spinal cord injury. This can have a serious impact on these older adults. As parents or as patients with spinal cord injury age, both individual aging changes and length of time since injury can affect functional ability. For example, bowel and bladder dysfunction can increase with the duration and severity of spinal cord injury. Health promotion and screening are important for the older patient with a spinal cord injury. Daily skin inspections, UTI prevention measures, and monthly breast exams for women and regular prostate cancer screening for men are recommended. Cardiovascular disease is the most common cause of morbidity and mortality among older adults with a spinal cord injury. The lack of sensation, including chest pain, in those with high-level injuries may mask acute MIs. Altered autonomic nervous system function and decreases in physical activity can place the patient at risk for cardiovascular problems, including hypertension, and health promotion to decrease the risk of injuries includes fall prevention strategies, such as using a step stool or a grab bar to reach high shelves and handrails on stairs. Rehab for an older person who has a spinal cord injury may take longer because of other pre-existing conditions and poorer health status at the time of the initial injury. An interdisciplinary team approach to rehab is essential in preventing secondary complications associated with spinal cord injury, especially in older adults. Let's do a few questions. A patient is just admitted to the hospital following spinal cord injury at the level of T4. A priority of nursing care for the patient is monitoring for what? Return of reflexes, bradycardia with hypoxemia, effects of sensory deprivation, or fluctuation in body temperature. The answer is B. Neurogenic shock is due to loss of vasomotor tone caused by injury and is characterized by hypotension and bradycardia, which are important clinical clues. Loss of sympathetic nervous system innervation causes peripheral vasodilation, venous pooling, and decreased cardiac output. These effects are generally associated with a cervical or high thoracic injury at T6 or higher. Injury or fracture below the level of C4 results in diaphragmatic breathing if the phrenic nerve is functioning. Even if the injury is below C4, spinal cord edema and hemorrhage can affect the function of the phrenic nerve and cause respiratory insufficiency. Hypoventilation almost always occurs with diaphragmatic respirations because of the decrease in vital capacity and tidal volume, which occurs as a result of the impairment of the intercostal muscles. Cervical and thoracic injuries cause paralysis of abdominal muscles and often intercostal muscles. Therefore, the patient cannot cough effectively enough to remove secretions, leading to atelectasis and pneumonia. An artificial airway provides direct access for pathogens, making bronchial hygiene and chest physiotherapy extremely important to reduce infection. Neurogenic pulmonary edema may occur secondary to a dramatic increase in sympathetic nervous system activity at the time of the injury, which shunts blood to the lungs. In addition, pulmonary edema may occur in response to fluid overload. A young adult is hospitalized after an accident that resulted in a complete transection of the spinal cord at the level of C7. The nurse informs the patient that after rehab, the level of function that is most likely to occur is the ability to do what? Breathe with respiratory support, drive a vehicle with hand controls, ambulate with long leg braces and crutches, or use a powered device to handle eating utensils. The correct answer is B. A patient with an injury at the level of C7 to C8 may have the following rehab potential: ability to transfer self to the wheelchair, roll over and sit up in bed, push self on most surfaces, perform most self-care, use a wheelchair independently, and drive a car with powered hand controls, and have attendant care 0 to 6 hours a day. And finally, and last but not least, during assessment of a patient with a spinal cord injury at the level of T2 at the rehab center, which finding would concern the nurse most? A heart rate of 92, a reddened area over the patient's coccyx, marked perspiration on the patient's face and arms, or light inspiratory wheezes on auscultation of the lungs. The correct answer is C. Autonomic dysreflexia is a massive uncompensated cardiovascular reaction mediated by the sympathetic nervous system. It occurs in response to visceral stimulation once spinal shock is resolved in patients with spinal cord lesions. The condition is a life-threatening situation that requires immediate resolution. If resolution does not occur, this condition can lead to status epilepticus, stroke, MI, and even death. Manifestations include hypertension up to 300 millimeters of mercury systolic, throbbing headache, marked diaphoresis above the level of the lesion, bradycardia at 30 to 40 beats a minute, piloerection, which is erection of body hair as a result of pilomotor spasm, flushing of the skin above the level of the lesion, blurred vision or spots in the visual fields, nasal congestion, anxiety, and nausea. That concludes our study of spinal cord injury.